SDG 3. Ensure healthy lives and promote well-being for all at all ages. Maternal mortality rate. This indicator is for the estimated number of women between the ages of 15 and 49 dying from pregnancy-related causes whilst pregnant or within 42 days of the pregnancy's termination. The long-term aim is 3.4 deaths from these causes per 100,000 live births. Globally, the estimated maternal mortality ratio was 211 per 100,000 live births as of 2017, well above the long-term goal. The maternal mortality rate is a proxy for the quality of a healthcare system. Complications due to pregnancy and childbirth can be common, but with proper care, healthcare professionals can handle difficulties, preventing the worst outcomes. Without proper healthcare available, it's more difficult to prevent, diagnose and treat any complications arising due to pregnancy. The LDCs and Sub-Saharan Africa are mostly off track on this measure, with the rest of the world on track, an illustration of how linked challenges are around it to insufficient healthcare. The same is true here for other indicators already mentioned, which have a strong correlation between a red score and LDCs. That is, OECD countries will shoulder the responsibility on behalf of the LDCs in the form of giving 0.7% of gross income as foreign aid. This giving will afford an army of skilled birth attendants in rural areas, as well as affording medical techniques taken for granted in the developed world. For example, blood transfusions, asepsis, and preventive prenatal care. A skilled health attendant can curtail these risks by caring for the mother during the pregnancy, childbirth, and postpartum period, including any postpartum bleeding or an obstructed labour. If aid flows to the LDCs and other aid recipient countries, the global maternal mortality rate can drop, achieving a measure which had its own goal in the Millennium Development Goals, which was MDG number 5, improve maternal health. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to reduce the global maternal mortality rate to 3.4 per 100,000 live births by 2030. Neonatal mortality rate. This indicator measures the number of newborns per 1,000 live births who die within 28 days following birth, with a long-term aim of a neonatal mortality rate of 1.1 per 1,000 live births. Causes of infant mortality in the first 28 days include deprivation of oxygen, congenital birth defects, prolonged labour, infection, low birth weight, and poor sanitation. The absence of healthcare raises the risk factors for neonatal mortality. As with the prior indicator, such is the priority of infant mortality, it warranted its own Millennium Development Goal, which was MDG 4, reduce child mortality. The correlation between extreme poverty and high birth rates also exacerbates neonatal mortality. As we reduce extreme poverty, birth rates will in turn reduce, as is the demographic trend observed worldwide. Therefore, we must encourage gender equality, women's empowerment in the labour force, as well as educating girls. The 2022 SDG index map for this indicator is uniform with the prior indicator, again highlighting the link between mortality rates for both mothers and neonates. Again, there's a strong correlation between LDCs and those countries with red scores. Thus, the responsibility again lies with the OECD countries to finance improvements in healthcare in the LDCs. The 0.7% of gross income of OECD citizens will finance the outreach of a mass workforce of skilled community health workers with resources on hand to meet the needs of rural areas. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to reduce the global neonatal mortality rate to less than 1.1 per 1,000 live births by 2030. Mortality rate, under 5 per 1,000 deaths. The distinction between this indicator and the previous is age. This indicator measures the number of children under 5 per 1,000 who will die before reaching age 5. The long-term aim for this indicator is 2.6 deaths for children under 5 per 1,000, down from the 2019 rate of 37.7. As such, this measure of children under 5 also includes neonatal and infant mortality. The leading causes are premature births and infections, especially pneumonia, diarrhea, and malaria. But the prevention measures are like the two prior indicators. That is, we need to finance public health needs. Most child deaths are preventable and cheap to treat and prevent, yet the cost is irrelevant without the meagre funding forthcoming. We therefore need to fund vaccines, antibiotics, mosquito nets, fluid replacement, promotion of breastfeeding and hand washing, as well as improved sanitation and drinking water facilities. A meagre 0.7% of your income will make you a literal hero, saving lives without a cape, cowl, or superpowers, just a bank account, a charity, and a device to make the transfer. Rather than treating a diarrheal infection or making the trip to Africa, you pay someone to do it on your behalf, then get to go to bed knowing you've saved the lives of helpless children. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to reduce the global under 5 mortality rate to less than 2.6 per 1,000 live births by 2030. Incidence of tuberculosis. This indicator estimates the number of cases per 100,000 people with either new or relapsed cases of TB, inclusive of cases for those living with HIV. The long-term goal is 0 cases of TB per 100,000 from a current global rate of 127 per 100,000 in 2020. TB is an infectious disease caused by a bacterium affecting the lungs with symptoms of coughing bloody mucus, fever, and night sweats, though TB can be asymptomatic at the same time as being contagious. Mycobacterium tuberculosis spreads by aerosol droplets micrometers wide. As suggested in the indicator's definition, cases of TB often occur alongside HIV/AIDS. TB is a disease of poverty, exacerbated by slum living, as well as malnutrition and poor sanitation conditions. Before the COVID-19 pandemic, TB was the highest cause of death from an infectious disease. A quarter of the global population may carry the disease in its latent form, with an annual rate of new infections of 1%. An estimated 10 million people have active cases worldwide, resulting in 1.5 million deaths, close to half occurring in Southeast Asia and a quarter in Africa. In many countries, the diagnosis and testing of TB can be difficult, slow, or unavailable. Many poor countries, or poor parts of middle-income countries, are without affordable X-ray facilities or affordable and accessible testing based on sputum cultures or other means. A preventive measure is keeping from contact with known TB cases. You will be at greater risk if your immune system is low, a risk factor often caused by the generalities of poverty. Enter the responsibility of high-income readers to improve poverty in all its dimensions via aid. We'll address HIV/AIDS in a later SDG 3 indicator, but taking preventive measures for HIV infection will affect the degree to which one may be at risk of TB. Prevention is difficult due to the poverty conditions it thrives in, so treatment may be our best option. The vaccine for TB is the most widely used in the world, with an estimated 88% of all children vaccinated for TB, though the vaccine has less than complete efficacy. TB can be treated with antibiotics, but resistance has become an issue with a growing prevalence of drug-resistant cases. TB carries with it many factors affecting successful prevention and treatment, sometimes with complexity on a scale addressed by public health efforts of national governments or international agencies like the WHO. For new cases of active TB, the patient should seek medical care where available, to undergo a regimen of antibiotic medications for up to 6 months. For recurrent cases of TB, a medical professional will need to find out which antibiotics in a treatment regimen are proving resistant. Testing may need to investigate whether the strain of TB in one system is multi-drug resistant, whereby the patient may need the other antibiotics in their regimen, which are yet to prove resistant for a longer course up to 1 to 2 years. If you're finding it challenging to scrounge enough money to feed your family and yourself, having ready access to testing and treatment, if paid out of pocket, in contrast to government funded, could be crippling to a household. You see how important it is for us to fund organisations like the WHO to carry out the work either households or national governments are unable to. Humanity has been battling TB since antiquity, a formidable foe. But we can manage TB at the population level if resourced and financed, as the rich countries did within their societies. Of course, the $8 we've been discussing from our rich country readers are going to go toward TB to aid public health efforts. The path to achieving the long-term aim of this indicator lies in the large advantage of SDG 3, that is, healthcare for all. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to end TB by 2030. For developing country readers, vaccinate, including your children, if symptomatic, seek diagnosis if available and affordable, and if diagnosed, seek treatment where available and affordable. New HIV infections. The issue of HIV, alongside malaria, had its own Millennium Development Goal, MDG 6, which was combat HIV/AIDS, malaria, and other diseases. This indicator is aiming for a rate of 0 new infections per 1,000 uninfected populations by 2030. In the past decade, global deaths from AIDS have halved, yet still can kill 1 million people a year. In some countries, AIDS is the leading cause of death, resulting in 1/4 of all deaths. The concentration of new HIV cases is in sub-Saharan Africa below the equator. Several of the southernmost African countries are now middle-income countries, for example, South Africa, Namibia, and Botswana. Each of these countries very much in the grips of HIV/AIDS. A cure is yet to be discovered, but the treatment or management of HIV/AIDS, when financed and resourced, is encouraging via the use of antiretroviral drugs. These drugs are inexpensive to manufacture, but even their modest cost may be high for households living in extreme poverty. A national healthcare budget must cover the costs of these drugs, though when national governments are too poor to do so, we turn to the international donor community to step in. For middle-income countries with high rates of new HIV infections, the message is the same as public health promotion efforts. We first need to acknowledge the infection known as AIDS is caused by a virus, therefore is a transmissible infection, spread via blood, semen, vaginal lubrication, and pre-ejaculate. The use of condoms, whether one's sexual partner is a known carrier of the virus or unknown, is essential. You can seek a diagnosis of HIV/AIDS via a sample of either blood serum, saliva, or urine. If one suspects they may have had a sexual encounter with a carrier of the virus, it's an opportunity to further prevent spread and receive management of the worst effects of AIDS if transmission has occurred. If you're a carrier of the virus and planning a family, transmission can occur to the baby via the course of pregnancy, childbirth, and the expression of breast milk. If you suspect you may have exposed yourself to the virus and are in a region where the following is available and affordable, you could use the treatment known as post-exposure prophylaxis, which could prevent exposure to the virus from turning into AIDS. Though a vaccine is yet to be discovered for HIV/AIDS, with financing for medical research, a breakthrough may occur before 2030. Antiviral drugs are available for treatment for those who've received a diagnosis of HIV/AIDS. For OECD readers, it's time to mobilise your 0.7% of gross individual income. Some circumstances of poverty offer more of a fertile ground for the virus's spread than in more affluent countries. Immune systems are already low for those living with malnutrition or absent healthcare, compounding the effects of a virus targeting the immune system. We've seen earlier how active infection by TB puts individuals living with HIV/AIDS at increased risk. Subpar sanitation conditions in medical settings could place at-risk individuals to transmission. Also, many sub-Saharan African countries may have cultural or religious attitudes hindering the use of condoms. As such, public health promotion efforts need funding to reach these communities. Universal healthcare, per the aims of SDG 3, must be made available and affordable to all. Healthcare systems can then observe signs and symptoms. Health promotion efforts can mitigate transmission via behavioural change, and we can champion the further financing of medical research. This is an issue of financing. From the financing, everything flows, from research, prevention, and treatment. We can bring HIV/AIDS to a rate of 0 new infections per 1,000 population, but the key variable is the dollars. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to end new cases of HIV by 2030. For developing country readers, use condoms. If you suspect you may have been exposed to HIV, get tested, and if you receive a positive diagnosis, seek treatment by antiretroviral drugs where affordable. Age standardized death rate due to cardiovascular disease, cancer, diabetes, or chronic respiratory disease in adults aged 30 to 70 years. Whereas TB and HIV are infectious diseases involving the spread of a pathogen, the diseases for this indicator are all non-communicable diseases, or NCDs, which come with altogether different risk factors. The more thorough definition of this indicator is the likelihood of death between the age of 30 and 70 from the diseases mentioned in the indicator title, who will die before turning 70 from those diseases. The main point is to try to mitigate falling prey to these diseases before your 70th birthday. The long-term aim for this indicator is for 9.3% or less between 30 and 70 to die from these diseases. Let's profile these diseases to see what you can do to protect against dying from them before you turn 70. Cardiovascular systems circulate blood throughout our bodies, transporting nutrients, hormones, and oxygen to and from cells. It aids in our immune system, regulates our body temperature, and maintains homeostasis. Cardiovascular diseases are the leading cause of death in the world by quite a margin, followed by cancer, then respiratory disease and diabetes. Causes of cardiovascular disease include high blood pressure, which you can be alerted to by a sphygmomanometer, the inflatable cuff fitted to your arm by doctors and nurses. Smoking is a cause, as is lack of exercise, obesity, high cholesterol, poor diet, drinking too much alcohol, and diabetes. How do you prevent cardiovascular disease? Abstain from smoking, eat healthily, drink alcohol in moderation or abstain altogether, and exercise. These are hackneyed commonplaces, seeming so obvious and simple, yet they so easily elude us, essential for healthy functioning. The second leading killer worldwide is cancer, the abnormal growth of cells, leading to the invasion of these cancerous cells into neighbouring tissues, which can then metastasize throughout the body. This contrasts with benign tumours, which leave neighbouring cells alone. The drivers of this disease are known as carcinogens, which include tobacco smoking, the cause of close to a quarter of all cancer deaths. Other major causes match with the risk factors for cardiovascular disease, including obesity, diet, sedentary lifestyles, alcohol abuse, and radiation. 70% of all cancer deaths occur in low and middle income countries. A third of the prevalence in these countries is due to hepatitis, the human papillomavirus, and a couple other bacterial and viral infections, including HIV. Less robust access to diagnosis and treatment in developing countries exacerbates this, where presenting to a medical professional in the late stages of cancer is a sad commonplace. Developed countries enjoy coverage of 90% comprehensive treatment of cancer, whereas low-income countries can only expect 15%. Cancer screening, where recommended by public health authorities for your given age or sex, is important to adhere to. Our less affluent counterparts may be missing access to such regular screening, as is promoted in many developed countries. The success of screening is one of the reasons death rates from cancer have dropped in the developed world. Medical imaging technologies are expensive, but if you have affordable access to seek cancer screening, please do so. Otherwise, the foreign aid spoken about throughout this book allows for the universal uptake of screening before 2030. To limit your exposure to carcinogens, you can limit your alcohol intake, as alcohol is a group 1 carcinogen, alongside processed and red meats. What risk factors can we mitigate in our personal lives as preventative measures? Early detection is important where your healthcare system is capable, as is appropriate treatment and care. Eat fruits, vegetables, and whole grains, and exercise regularly. Get vaccinated against human papillomavirus and hepatitis if you have access in your country. Limit overexposure to the sun or occupational radiation exposure. Limit exposure to carcinogenic chemicals and agents common in some occupations, including outdoor and indoor pollution. Seek screening where available in your country. This is of urgency for cervical pap tests and mammography screenings for breast cancer. The ethanol in alcoholic drinks metabolizes into the carcinogen acetaldehyde. Consider what effects alcohol has and whether it's worth putting yourself and your loved ones at the tragic scene of your deathbed. If, in this example, and of tobacco smoking, you feel it's beyond you to quit this addictive practice, chat to your GP. It's what they're there for. Diabetes is a modern-day disease of our behaviours and poor choices. I've said enough elsewhere in these pages about the perils of processed food and refined sugar playing havoc with our insulin response. I recommend Dr. Robert Lustig's illuminating book, Metabolical, if you're curious for a deeper dive. We can characterise a healthy lifestyle by a healthy diet high in fibre and whole grains, with sparing to zero consumption of refined sugars. Limiting ultra-processed carbohydrates and saturated fats is essential. These diet choices are healthy for people and the planet, as is regular exercise. It's simple, but is why we underestimate the benefits of such helpful habits. If we eat well and exercise, we ought to keep our body weight in a healthy range, which otherwise would become another diabetes risk factor. As Dr. Lustig says, the simple mantra to curb metabolic diseases like diabetes is to protect the liver and feed the gut. The latter means to eat high-fibre foods which feed the bacteria coexisting in our intestines as walls, which digest the fibre before the rest of our body has the chance. Protecting the liver means avoiding processed foods and refined sugars, which put a strain on the functions of the liver, sometimes overwhelming it, leading to the accretion of fatty deposits. Drink alcohol in moderation, or abstain altogether with your liver's health in mind. Abstain from eating refined sugar, white carbohydrates, and saturated fats, and please abstain from eating foods containing all three. Such concoctions together are like the nutritional equivalent of a speedball. This indicator focuses on chronic forms of respiratory disease rather than short-term occurrences such as the common cold, flu, or COVID-19. Chronic forms include asthma, emphysema, and chronic bronchitis. Smoking is a controllable risk factor, though less controllable is air pollution, plus exposure to occupational chemicals and dust. There's yet a cure to many forms of chronic respiratory disease, but treatments can dilate airways to aid shortness of breath. You can attempt to limit exposure to harmful particulate matter in the air around you, if you're aware of it, by limiting the release of particulate matter, whether indoors, outdoors, or of an occupational nature, or in a residential setting. Any dust or fine matter suspended in the air is putting you at risk. Dust may seem innocuous, as it's all-pervading, but often is harmful. Our foreign aid from OECD readers will finance the adoption of cooking methods for those living in poverty, as many cooking methods used among the extreme poor are a cause of indoor pollution from the fumes of biomass, accompanied by poor ventilation. You already know smoking tobacco is harmful to health. You may be unable to control genetic factors, but you can control the degree to which you expose yourself to further risk of the above causes of chronic respiratory disease. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, and for developing country readers, mitigate the risk factors. If experiencing symptoms, seek diagnosis, and if diagnosed, seek treatment where affordable and available. Age standardized death rate attributable to household air pollution and ambient air pollution. We touched on the issue of air pollution as a cause of death in the prior indicator, in the context of it being a risk factor and a carcinogen. This indicator targets a mortality rate caused by air pollution of 0 per 100,000 population by 2030. We see household air pollution in developing countries using biomass as cooking fuel in the form of wood, charcoal, dung, or crop residues left over in an agricultural field after the harvest. The exhaust gas from combusting the above contains particulate matter, which are microscopic particles suspended in the air, such as carbon monoxide, nitrogen dioxide, sulfur dioxide, and a bunch of organic pollutants. By contrast, ambient air pollution in the atmosphere has adverse consequences to human health, as well as the Earth's climate when in the forms of nitrous oxide, methane, carbon dioxide, and chlorofluorocarbons. We know carbon dioxide is a driver of climate change, affecting the natural environment, destroying habitats, and hurting human health. Chlorofluorocarbons result in the depletion of the ozone. Many of the above chemical substances are also toxic to the organisms absorbing them. Ambient air pollution can cause acute respiratory tract infections and is also a risk factor for cardiovascular disease, including stroke and lung cancer, in addition to evidence of its relationship between depression and prenatal development. We've known for a long time that air pollution in all its guises is damaging for human health. But the death toll has become startling, estimated to kill 7 million people a year, as well as costing the global economy $5 trillion, with an estimated 90% of the global population breathing dirty air. The data we're looking at combines deaths from ambient and indoor air pollution, but we can estimate the high death rate in sub-Saharan Africa is due to dirty cooking stoves. The global development community has been seeking to remedy this with the distribution of clean cooking stoves to the world's poorest to prevent these needless deaths. Pneumonia is still the world's biggest killer of children by infectious diseases, for which indoor air pollution is a risk factor. The LDCs are short of the domestic resources to resolve this of their own accord and will need help to reinforce their budgets. Aid workers can try to help ease the adoption of clean cooking and heating stoves in homes. What if you're a reader from an LDC, or anyone living in a country scoring red or orange for this indicator, and are combusting solid biomass in your home? Please attempt to ensure there's enough ventilation to keep combustion from polluting the surrounding environment of the living space. Some of the above-mentioned chemicals are microscopic, so even in the absence of smoke, there can be danger. Carbon monoxide being a good example of an invisible killer. We're pinning our hopes to achieve the clean cooking stove issue via the international donor community paying for this on behalf of the extreme poor. Whatever the suite of solutions, we'll return to this in Goal 7, which is affordable and clean energy. What can we do about ambient air pollution? What we pollute in the immediate vicinity will be lurking in the nearby atmosphere. Yet, over time, we share the same air. In other goals, we'll look at the effects of many of the air pollutants, and we'll see throughout the coming indicators the degree to which we ought to be curbing carbon dioxide emissions. In SDG number 12, we'll see further how industry ought to curb its emissions of sulfur dioxide and nitrous oxide. Some simple solutions include eschewing internal combustion vehicles, assisting in the phase-out of fossil fuel vehicles toward electric vehicles, prioritize more sustainable transport modes, including cycling, limit air travel until aviation fuel becomes less polluting, adopt a lifestyle more characterized by localism, reducing your need for transport, and use electricity generated from clean, renewable energy, including heating. For anyone running or managing an industrial operation, control devices should be of priority for the consideration of human health. If you live in a democracy and have a representative elected on your behalf, you can write to them to affirm your request for stringent air quality laws. We know for the LDCs, our 0.7% foreign aid from OECD readers will help finance solutions to the main source of indoor air pollution. The OECD countries are all on track for this indicator, and may in some cases have more stringent air quality laws. A healthcare system resourced and financed to treat diseases born of airborne pollutants is a vital factor in their success, despite playing their part as sources of air pollution in faraway countries. For middle-income countries scoring red or orange for the indicator, it's crucial governments prioritise health systems and healthcare spending to meet the high toll of disease caused by elevated levels of air pollution before such diseases become fatal. In summary, for all readers, be mindful of emissions contributing to ambient air pollution, that is, greenhouse gases, ozone, particulate matter, or PM 2.5, sulfur dioxide. For OECD country readers, annually give 0.7% of your gross income as aid, aiming to end deaths from air pollution by 2030. For developing country readers, use clean cooking fuels where available and affordable. Traffic deaths. This indicator aims by 2030 for 3.2 deaths or less from traffic per 100,000 people. To mitigate the risks of vehicle collisions, you can drive free from the influence of intoxicating substances, remain focused from mobile phone distractions, follow the rules of the road, including observing speed limits, ensure while driving to have a clear distance ahead of the vehicle in front of you, be mindful of poor vision or a disability, if this may have progressed since you last underwent a driving test, pertinent for those of old age, Be mindful of your disposition whilst driving, including if you find yourself irritable. Consider what is or is not displayed in your side view mirror. Be careful in low visibility through the windshield in fog conditions. As a driver in society, adopt a culture of safety. If riding a motorcycle, be mindful of the necessary safety precautions, including personal protective equipment. What of the lack of universal healthcare in poor countries with high traffic fatality rates? Some of these deaths could have been prevented had enough medical care been available, keeping a road-related injury from being fatal. We've already seen how donor help goes a long way toward building up the healthcare systems so medical access is universal, which could bring down traffic fatality rates. You're attempting to lower traffic fatalities, which you as an individual reader have the power to control. But if you feel concerned about a certain stretch of road as it relates to safety, you may wish to alert this to the attention of the local road authority. They may very well remedy this upon your request if it poses a risk to road safety. If you work in the automotive industry at any level, be mindful of risks in the production or design process which could endanger drivers. Driving a vehicle at a speed of 60 kilometers an hour or more is a big responsibility for anybody getting behind the wheel. You must drive safely and accommodate your capacity for human error, as well as be aware of the fallibility of other drivers, pedestrians, cyclists, or motorcyclists. Middle-income governments ought to have a greater capacity to enforce road rules than their low-income counterparts and provide the resources in healthcare to care for those injured in crashes. This could mean transport planning more attuned to road safety and improving vehicle safety mandates for cars. As well, this could mean public education targeting drivers to better the culture of safety on the roads. In summary, drive safe, heeding the above points, aiming to reduce national traffic deaths to less than 3.2 per 100,000 population by 2030. Life expectancy at birth. The fuller description of this indicator is the average years an infant can expect to live if exposed to age and sex-specific death rates in the country of their birth, aiming for a life expectancy of 83 by 2030. The global average is 73 as of 2022. Most of the developed countries are on track for this indicator in the 2022 SDG index, with a glaring exception of the US, where life expectancy is falling. The priority countries are the LDCs, with low life expectancy in poor countries due to the demographic effects of high child mortality. Let's compare Angola and Afghanistan as examples to examine causes of death in countries both scoring red in the 2022 index. Both have life expectancies at birth of 63 using 2019 data. In Angola, the leading causes of death are neonatal conditions, lower respiratory infections, TB, diarrheal diseases, malaria, and HIV/AIDS. In Afghanistan, the leading causes of death are heart disease, neonatal conditions, collective violence, stroke, lower respiratory infection, and TB. We see in Afghanistan a combination of deaths through communicable diseases, perinatal and non-communicable diseases, as well as collective violence due to war. The top 6 leading causes of death in Angola were all either communicable or perinatal. Both countries have a need to address poverty, requiring enough nutrition, healthcare systems, and water and sanitation to meet their basic needs. Otherwise, infectious diseases and diseases of poverty will continue to remain rooted, and we can expect the life expectancy of these countries to continue to stagnate. Nature has spared Afghanistan from the petri dish of infectious diseases endemic to much of the tropical LDCs such as Angola. Still, Afghans have had to contend with what seems like an ongoing war with one aggressor or another for decades to centuries. Such conditions make for less than fertile ground for healthcare systems to take root or for an upward trajectory of life expectancy. What can readers do vis-à-vis our LDC compatriots? The foreign aid we're donating will lift them from poverty in all its dimensions, inclusive of financing health for all. What can readers do for poor countries in conflict, like Afghanistan or Yemen? Is your government perpetuating such conflict for cynical ends? If you believe so, contact your government representatives to declaim against your country's tacit or overt support for such conflicts at the expense of the citizenry. What about middle-income country readers? The quality and accessibility of healthcare where you may live may be beyond your scope to control, though seeking medical attention where available may be within your control. The simplest route is a healthy life, characterized by a healthy diet, regular exercise, and limiting or eliminating harmful behaviors like alcohol abuse and smoking. Be a little more mindful of the leading causes of death in your country, which you may be most vulnerable to in your circumstances. You can check what those top causes are on the WHO website, and from there you can discover what the risk factors are for those causes, ensuring you're limiting any behaviours which may speed up their effect on your health and lifespan. It's likely the leading causes of death in middle-income families will be non-communicable. If so, it'll be worthwhile to revert to the earlier indicator relating to NCDs and what you can do to mitigate their onset. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming for a global life expectancy at birth of 83 years by 2030. For middle-income country readers, have a healthy diet, regular exercise, and be mindful of risk factors. Adolescent fertility rate. This indicator is aiming for 2.5 births per 1,000 women aged 15 to 19 by 2030, down from a global rate of 41.5 in 2019. The 2022 SDG index map for this indicator shows a split result across the world between half the globe scoring green and the other half red or orange. Close to the entirety of Latin America scores red or orange, as has Sub-Saharan Africa and about 10 countries across Asia. In developing countries facing challenges on this indicator, teens falling pregnant may often have gotten married, seen as a good thing to the broader society and family. Yet many of these countries face issues with malnutrition and underdeveloped healthcare access, compounding any complications with the pregnancy and threatening maternal and infant mortality. This issue is acute in Sub-Saharan Africa, where we can expect a demographic explosion throughout this century, whereby elevated levels of extreme poverty will result in high birth rates due to anticipated high rates of child mortality by families. What is the solution to curbing such a demographic explosion? The region is already unable to support its existing population due to the depredations of extreme poverty, yet is expected to add up to 1 billion more souls to share in its already slim domestic resources. Interweaving with Goal 5, the key is for teenage girls to remain longer in education and to value them as staples of the labour market. You can encourage their value to society such that families will see their greater worth by working or studying rather than marrying young and starting a family. This is especially true between 13 and 19 years of age, when young women may yet feel they have the resources to care for themselves. Cultural attitudes will differ wherever in the world one finds high rates of teenage pregnancy, and to shift to these attitudes can be difficult. But we're only looking to influence the sample size of one, that is, you. You need to reconcile any attitudes you may hold related to your society's traditional practices and mores with those of the SDGs. This indicator resides within goal number 3 because there are risks with teenage pregnancy of low birth weight, preterm births, seizures in the mother from high blood pressure, anemia, lack of access to prenatal care, and development psychology issues of the child. We need to emphasize educating girls and lift them from poverty. What about girls in LDCs scoring red on this indicator? We know by now our DAC readers will transfer foreign aid to reduce the conditions of poverty, which can also finance comprehensive sex education and access to birth control. Core to this is keeping girls in education if possible, a sentiment at the heart of goal number 4. The opportunity cost to the economy is a woman lost to the labour market as a wage earner for her family and self. If you're a reader in an off-track country other than an LDC, you may have better access to resources than a counterpart living in extreme poverty. The most valuable forms of prevention of teenage pregnancy are sex education and birth control. Be forthright with yourself within your conscience. There is a real-world imperative to bring teenage pregnancy rates down. We must decide which takes precedence. Is it our pre-existing beliefs or the principles of sustainable development ensuring human health? There's room to try to find compromise in a way allowing for your conscience to be at relative ease. Global adolescent fertility rates are at present incompatible with public health. At the heart of any reservations about sex education and birth control is an overarching concern for the sanctity of human life. Yet the greatest expression of this sentiment is to compromise on what we thought we valued in the sacrifice of what is healthiest. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming to reduce the global adolescent fertility rate to 2.5 births per 1,000 females aged 15 to 19. For developing country readers, encourage women to wait until adulthood for marriage and childbirth, prioritising labour force participation and education. births attended by skilled health personnel. This indicator reflects a crucial necessity of all the indicators thus far explored relating to maternal and infant health. The goal by 2030 is for 100% of births attended by healthcare workers skilled in care during pregnancy, childbirth, and the postpartum period. This could include midwives, medical doctors, obstetricians, or nurses. All can respond to any complications related to the pregnancy, offering prenatal care in a healthcare facility, whether a doctor's clinic or hospital, or even a home. As of 2018, skilled health personnel attend 80% of global births. Off track in the 2022 SDG index is most of the African continent, South Asia, and several Southeast Asian and Latin American countries. This indicator is very much consistent with goal number 3 to offer healthcare for all, as birth attendants are often the very first step in the life of someone beginning life. Health professionals practicing as birth attendants will need different standards of skill. In extremely poor, remote areas of developing countries, the standard of how skilled a birth attendant needs to be may entail less formal training due to the lack of skilled birth attendants. In 2020, the split between births attended by skilled health personnel was 70% rural versus 90% urban. Those countries with major challenges remaining for this indicator need more robust healthcare. We could train a vast labour force in each of these lagging countries and mobilise them to ensure all receive healthcare. The crucial factor is financing to build the network. The key task for most readers will be to assist those living in extreme poverty in rural areas. Sometimes this means in middle-income countries with patches of dislocated, remote populations, like Bolivia, the Philippines, Morocco, or Guatemala, all scoring red on this indicator. Our foreign aid must reach these isolated mothers. Further, the governments of these countries must prioritise their domestic resources to ensure they offer healthcare to all corners, inclusive of skilled birth attendants attending all births by 2030. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming for all births to be attended by skilled health personnel by 2030. For developing country readers, if you're an expecting reader, ensure a skilled health professional attends your birth, even if the skilled professional is in tandem with a traditional birth attendant. Surviving infants who received 2 WHO recommended vaccines. The aim by 2030 is for all infants under 12 months of age to receive their first dose of the measles shot, as well as the third dose of the DPT vaccine, which combines diphtheria, pertussis, also known as whooping cough, and tetanus. The 2022 scores display most of the LDCs and countries in conflict facing challenges on this indicator, as well as many middle-income countries. The WHO estimates 20 million infants have insufficient access to vaccines. In the instance of LDC countries off track, we expect our DAC readers will pick up the slack to finance this gap to reach 100% coverage by 2030. This includes costs for production, distribution, and administration of the vaccines to infants. We're inviting a swath of the global population to fall through the cracks when a healthcare system could otherwise offer them coverage. Producing these specific vaccines is an affordable cost to developed world readers, but it is beyond reach for those living at or below subsistence. The developed world also needs to foot the remaining bill for the training or wages for those administering the vaccines. If you're a reader in a middle-income country, you should have affordable access to the measles and DPT vaccines. If you're a parent or guardian, please immunise your child with those WHO-recommended vaccines. It may well be that your country's national routine immunisation program for infants is subpar. If so, you can contact a government representative to request a more robust national immunisation program, though you may need to seek out such immunisations out of pocket. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming for all surviving infants to receive the 2 WHO-recommended vaccines by 2030. For middle-income countries off track, vaccinate your infants younger than 12 months with the measles and DPT vaccines. Universal Health Coverage Index of Service Coverage. Universal Health Coverage, or UHC, cuts to the core of Goal 3 in its entirety, with Goal number 3 aiming for healthcare and well-being for all, with this indicator measuring this with the objective for UHC by 2030. The indicator includes treatment of the following within the definition of UHC: reproductive, maternal, newborn and child health, infectious diseases and non-communicable diseases. What can you do to ensure universal health coverage in countries off track? By now, readers might be able to answer themselves given the hint of the link between the least developed countries and low universal health coverage. Nevertheless, least developed countries and lower middle income country governments need to mobilise as much of their domestic resources as possible to ensure universal health coverage for their citizens. Although of greater emphasis, we know, is aid from the high income countries. Universal health coverage requires money to train personnel and develop the infrastructure of a health system accessible and affordable to all. Of course, the idea, rather than high-income country citizens financing the healthcare systems of the neediest countries in perpetuity, is for the least developed countries to gain a grasp on the bottom rung of the development ladder. They can then climb up further rungs, also reaching those living in extreme poverty in lower middle income countries like India. All these countries lagging on the indicator for meeting the aim of universal health coverage by 2030 will have their heads above the poverty line to finance universal health coverage if high income country readers meet aid commitments between now and 2030. Fostering the scale, skills, and quality of care necessary everywhere is a complicated, challenging task, but it's fundamental to the precepts of well-being at the core of sustainable development. It requires significant effort, much expertise, a skilled workforce, and the financing to pump the lifeblood through all these much-needed possibilities. We first need to give priority to the most disadvantaged, who are the furthest from coverage. In summary, for OECD country readers, annually give 0.7% of your gross income as aid, aiming for universal health coverage by 2030. Subjective well-being. This is one of my favourite indicators, drawing upon the World Happiness Report published by the Sustainable Development Solutions Network since 2012 and co-edited by SDG Index co-author Jeffrey Sachs. The World Happiness Report, rather than measuring the value of a country's output by economic means such as GDP or gross national income, instead measures the happiness of the country, that is, gross national happiness, or GNH. Bhutan pioneered the metric, including GNH in the country's constitution in 2008. Running an economy and society around the idea of happiness used to seem naive. Now happiness is in the realm of measurable science due to the work of the World Happiness Report and the body of work it draws upon. The World Happiness Report offers a score-based index akin to the SDG index based on ladder scores, that is, a measure of 0 to 10. Surveyors ask respondents how they perceive the well-being of their life, 10 being the highest. The long-term aim for this indicator is a score of subjective well-being of 7.6 out of 10. Compared to Finland, the number one ranked country in the 2022 World Happiness Report with a score of 7.8, 7.6 makes for a lofty ambition. Below Finland, only Denmark and Iceland scored 7.6 or over in the 2021 data. We can rank countries upon their sample sizes score for happiness. There's a good parallel between the countries topping the World Happiness Report's rankings and those of the SDG index. The Nordic countries are luminaries in each, Finland taking the top prize for both in 2022, although my understanding is the Finns would object to this as ludicrous and would be more content with a wooden spoon for the measure. Following are the top 10 rankings of the 2022 World Happiness Report and also the 2022 SDG Index to allow for comparison. Starting with the World Happiness Report, number 1 is Finland, followed by Denmark, Iceland, Switzerland, Netherlands, Luxembourg, Sweden, Norway, Israel, and New Zealand. To compare this with the 2022 SDG Index Top 10 rankings, these are Finland, Denmark, Sweden, Norway, Austria, Germany, France, Switzerland, Ireland, and Estonia. You can check your happiness by asking yourself the same questions the Gallup World Poll employs for subjective well-being. How do you rate your life? 10 being the best, 0 the worst. Whatever your score, rather than it being static, it can be improved upon. How do you make yourself happier? It seems a veritable existential question, but you can keep 6 explanatory factors, measured by the World Happiness Report, in mind to cultivate. The first of these is GDP per capita, followed by social support, healthy life expectancy, freedom to make life choices, generosity, and perceptions of corruption. I'll use my home country of Australia to expand on how the 6 explanatory measures constitute a happiness score. Australia's subjective wellbeing score is 7.1, akin to asking an average Australian, what do you give your life out of 10, with their response being approximately 7. Life is more complicated than 6 explanatory variables, but if you want to make some headway toward boosting your self-reported measure of subjective well-being for your life, a place to start could well be attempting to increase your income, strengthening or broadening your social ties, including the support of others, practice a healthy lifestyle to maximize your healthy lifespan, free of disease or disability, and donate monthly to charity per the definition of the generosity measure. They may seem simple prescriptions, but try them first and check in with your ladder score to see if it nudges the needle. Rather than expecting to go from 7 to 9 overnight, it'll be more incremental and moderate, but progress worth maximizing nevertheless. How do we tackle perceptions of corruption and freedom to make life choices? If you live in a corrupt dictatorship, which is a considerable population of the world, what do you do? All of Africa and South Asia score red for this indicator, as do any LDCs outside those regions, as well as several Middle Eastern countries either in conflict or bordering a country in conflict. Afghanistan is the lowest ranking country in the 2022 World Happiness Report, a country in conflict at the time of data collection, scoring 2.4 out of 10. For the least developed countries scoring red on this indicator, high-income country readers need to mobilise their foreign aid to boost, over time, the GDP per capita of the least developed countries to better the score of the strongest of the 6 explaining variables. 2 of the explaining variables further outside our control are the freedom and corruption measures, influential as they are due to the powerlessness one may feel. Like the GDP per capita explanation measure, if it's too challenging for you to increase income due to external circumstances, this is a cause for poor well-being. Incorporating all the topics already discussed relating to the Goal 3 indicators will contribute toward the healthy life expectancy explanatory variable. Better yet, if you have affordable access to a mental health professional, like a psychologist, put them to work. Go to your GP first to set off on this path if you think it might be suitable, which your subjective wellbeing score may well suggest. You may need medical attention for disorders of emotion, cognition, mood, or personality. If you live in a least developed country, it's improbable you can afford a psychologist, if there are any in your country at all. But the purpose of SDG 3 is good health and well-being, which means aiming for everyone to have such access by 2030. In summary, for all readers, maximize the explaining variables within your control, aiming for a subjective wellbeing score of 7.6 by 2030. Offer social support, that is, the ability to rely on someone in a time of need. Give to a charity monthly. Attempt to increase your income, and visit a mental health professional if affordable and accessible. For OECD country readers, annually give 0.7% of your gross income as aid. Gap in life expectancy at birth among regions. This measures the difference in highest and lowest life expectancy between a country's regions, aiming to narrow the gap to be non-existent by 2030, ensuring we leave no one behind due to where they live in the country. For this indicator, the OECD countries scoring red are Canada, Colombia, Australia, Turkey, and France. In Canada, this means the gap between the life expectancies of the country's provinces and territories. In Canada, the highest province or territory for life expectancy is Ontario, and the lowest being the northernmost territory, comparable to the life expectancy of Tajikistan. There's only one hospital in Nunavut, with 35 beds for the population of 37,000, compared to 17,000 beds in Ontario. While 11% of Ontarians smoke, the Nunavummiut rate is 65%. Between 2000 and 2007, the age standardized suicide rate was 71 per 100,000 population, compared to 7 per 100,000 in Ontario, 10 times higher. If Nunavut were an independent country, it would have the highest suicide rate in the world. The runner-up is another ethnic Inuit territory, Greenland, separated by Nunavut by the Baffin Bay and Davis Strait. Furthermore, a third of Nunavut Inuit attempt suicide. The high suicide rates are due to a variety of mental afflictions, characterized by a severe emotional reaction to an event, the catalyst of which can be a variety of conditions, including abuse, neglect, unemployment, school dropout, and relationship conflicts. Inuit in the Canadian Arctic are also eating foods low in nutrient density compared to the amount of energy in foods. That is, the ultra-processed foods explored in the SDG number 2 chapter. This food is high in sugar, fat, and refined starchy carbohydrates, but low in nutrients, all of which we already know add up to the elevated risks of non-communicable diseases. The Inuits are eating less traditional food and little fresh fruit and vegetables, reflecting the food insecurity of communities only accessible by air. Furthermore, a third of Inuit children lived below the poverty line in the territory. The reasons for poor nutrition could range from behavioural reasons linked to a legacy of colonial trauma, as well as the general food insecurity reasons synonymous with isolation. Differentials in the life expectancies of Indigenous people are common in colonial settler countries, further evidenced by Australia's red score for this metric. To remedy the above, the Government of Canada's Nutrition North Canada works to make nutritious food more accessible and affordable. Let's use the same mechanism we have for OECD countries toward least developed countries, whereby the fortunate apportion their relative prosperity to the less fortunate among us. That is, directing the attention of Ontarians to the health outcomes in Nunavummiut. In summary, for countries off track, residents of regions with the highest life expectancy can donate to a charity focused on health operating in the region with the lowest life expectancy. The aim is to eliminate the gap in life expectancy at birth among the regions by 2030. Gap in self-reported health status by income. This indicator traces health inequalities within countries, on this occasion based on income. It considers those within a country who self-report their health to be good or very good, comparing the poorest fifth to the richest fifth. The goal by 2030 is to close the gap between the upper and lower quintiles' self-reporting of health. Only the Czech Republic and the Baltics have scored red in the 2022 SDG index. We'll deal with income inequality with a much greater focus in goal number 10 for reduced inequalities, but social inclusion is central to all goals, as well as the concept of sustainable development overall. The Czech Republic is an equal country according to income inequality metrics, and its relative equality keeps its SDG index score among the world's highest. The 3 Baltic countries are a mix of income equality, though each is off track to varying levels. We're looking at health equity in this indicator and the social determinants of health. Health inequalities and diseases among the poor could be borne by those who are aging, lack shelter, have poor sanitation, face social exclusion, or are unemployed, leading to higher levels of chronic conditions and death. Why does this occur? It could result from childhood development, education levels, the time someone spent in the labour force, as well as the type of employment, and healthcare available across someone's lifetime. Gender inequality, as well as ethnic and racial prejudices, can also be drivers of health inequity, or may arise between those living in metropolitan areas compared to isolated communities, as seen in the regional indicator before. Gaps can also occur due to the health policies of different governments and social norms surrounding health behaviours. The Czech Republic and the Baltics have public health insurance, which ought to capture the poor, but is resulting in the poor still self-reporting worse health. Identifiable to the above countries is the post-Soviet nature of each. All are the former Soviet republics, or within the Eastern Bloc. To focus on Estonia, self-reporting on health seems consistent with other post-Soviet states, which could be a vestige of the legacy of the heavy industry of communism. Poor self-reporting of health also correlates with low education levels, and for men living in rural areas. Russian citizenship forms a quarter of the Estonian population, who may import their poor health and non-communicable disease outcomes to the more developed Baltics. Research shows being of Russian nationality, as well as education levels of Russian women, have a negative effect on Estonian self-reported health. The research observed another correlation of an individual's locus of control affecting self-reporting. This could be a byproduct of coming of age under the rule of a one-party socialist state atop actual poor health status. Another correlate was the emotional distress of transitioning from communism to a market economy, a dislocation experienced in all former Soviet and Eastern Bloc countries to varying degrees. To offer a contrast, Estonia and its neighbour across the Baltic, Finland, share similar socio-economic patterns of health, but self-reporting on health is much poorer in the former. Education may be the key determinant, accompanied by limitations on making healthy decisions, or a sense of the potential for social mobility. In summary, for readers in countries off track and in your country's top income quintile, compensate for the lower income quintile by donating to charities operating within your country focused on health and/or poverty. The aim is to close the gap in self-reported health status by income by 2030. Daily smokers. Most OECD countries are close to on track for this indicator in the 2022 SDG index. The aim by 2030 is for the percentage of people over age 15 smoking daily to be 1/10 of the population. Quit smoking, because it makes you a liability to yourself and everyone else, is the leading preventable cause of death worldwide. Taking a public health perspective on smoking tobacco, the prevalence of tobacco use is higher for those experiencing mental disorder, alcoholism, physical dependence on drugs, and homelessness. If you can avoid using tobacco in adolescence, all the better. If you want to choose to achieve this indicator more than you want to smoke, first contact your GP. Nicotine is such an addictive substance that you'll need medical help. Try cold turkey if you feel compelled to do so, but you have access to medication and nicotine replacement therapies. You might balk at the idea of medication, but if you reckon your neural circuitry can outwit the chemistry of nicotine, best of luck to you. Medication means substituting one chemical you heretofore had welcomed into your body for another. Nicotine withdrawal will be an unwelcome experience for you and those around you, with the attendant anxiety and depression it could induce. There are all manner of alternative ways of ceasing smoking which you might care to try alongside consultations with your GP. For example, acupuncture, hypnosis, herbal medicine, smokeless tobacco, aversion therapy, or even vaccines. In summary, quit smoking, aiming for 10.1% or less of the national population aged 15 and over to be daily smokers by 2030.